Good afternoon, everyone. And this is our opportunity to just bring you into the loop on our last board meeting. And today I'm with Steve, who's our finance director. So we thought we'd spend most of this session just thinking about money. But before we do, some really good news. We had a very substantial update at the last board on maternity and maternity safety. And for those of you who've listened to other ones of these podcasts will know it's been a real priority for us because of some of the pressures on the service and the need we've had to make improvements on the back of the Ockenden and the Kirkup reports and the Saving Babies' Lives bundles. And there's been a huge amount of work done. And I'd like to say that's not because we've had a bad maternity service. We've had a very good maternity service, and you only have to look at the feedback we get from service users to know that mothers and families are getting really good care. But we did have areas where we needed to strengthen and improve our practice, and we particularly needed to improve the recording of some of our practices. So we had an update from Dottie, our chief midwife, on all of that. And subsequent to the board meeting, we've had the official rating on our CQC visit. And we continue to be good on well led, and we continue to be good for safe, which means that we're good for maternity overall. And I always say the absolute service we're delivering for our service users is the main thing, obviously, and it's not how you are relative to everyone else. But you're not going to have to spend long on the CQC website to see that that puts us in a very good position relative to others. So we just needed to reflect on that, Steve, didn't we? Because I've lost track of how many conversations we've had about all of this. A very large number, and it's a great outcome from a long bit of work by Dottie and colleagues.
It is, absolutely. I think that was a fantastic conversation and outcome. I know a lot of time and effort from the various teams has gone into making this happen, and it's fantastic to see that recognition and also recognising the level of service and the kind of improvements we're making for our community. So yeah, a great outcome all round.
Yeah, and lovely, isn't it, to get that acknowledgement of all the hard work, because it's an important acknowledgement. You don't do it for the rating, obviously, you do it for your service users, but it's lovely when you know you're providing a good service to kind of have that badge of quality. And it's lovely comfort too, I think, for parents choosing to come here, that they kind of know that that's what they can expect. So I'm to be honest with you, I'm pleased and relieved.
Absolutely, great stuff.
So we should probably talk a bit about money, which was our other kind of big preoccupation at the last board, and indeed at many boards now in recent months. Because we're a bit challenged, aren't we, financially, Steve? And if you're in a role in the trust that's clinically facing, you'll be aware of some of this, but probably only peripherally. And I thought what we might do is just perhaps have a bit of a recap for folk about we were always a great trust, weren't we? And we were seen as very financially sustainable, and we were seen as very prudent and good stewards of our resources. And then things were getting a bit tighter for us as we came into COVID. Then we kind of had the period of kind of what I call COVID funny money, where, accounting protocols kind of had to change because of the pressures on the system. And now we've come out the other side of COVID and we're really, really feeling the pinch. How that's the layman's description. What would be the kind of more the better description of all of that for people who want to understand a bit more about why we are where we are?
No, so actually it's a really good description, Helen. So I think there's a real recognition that actually COVID hit and a lot of money got put into the NHS, which was quite right. We needed to respond to what was a national crisis. And a lot of money got pumped in to prioritise treating patients. And what's happening now is that money is effectively starting to be reduced from our budgets, which is obviously squeezing the finances. A lot of those costs are still sat within our cost base. Some of them have stopped. So, for instance, we're not spending quite as much as we used to on PPE or pathology testing, for example. But actually, a lot of the staffing cost increases that we've seen throughout COVID, we still see now. So a big driver in our financial challenges. We've actually seen a very significant growth in our workforce in the last 3 years. So I mean, that is quite common with a lot of other NHS organisations, but actually what we've seen in Chesterfield is that the scale of our workforce growth has been higher than the kind of regional average, if you like. I guess the other thing I'd draw out, Helen, is actually coming into COVID, whilst it's true that we were in a reasonably good financial position, certainly compared to others, we'd gone through a number of annual cycles of actually we had to use non-recurrent savings or one-off savings to actually help us hit those targets. And obviously there's a natural limit on how many times you can do those things. So, that was great at the time. It helped us for those financial years. But what that doesn't do is then it just pushes the problem onto the next financial year effectively.
And it's really hard, I think, for colleagues this because, the pressure we get from the powers that be external to the trust is you've more people than you've ever had and you're not doing as much work as you used to do when you had less people. Therefore, you must be unproductive, inefficient, otherwise questionable. But yet, when you talk to colleagues on the shop floor, they're saying, actually, we don't have enough staff and we can't give the sort of patient experience we would like to give. And, the system is creaking. And it's quite hard to reconcile those two versions of those realities. And of course, the headline answer you get a lot of the time is, oh, acuity has changed. And, during the pandemic, people didn't come forward, and now they're coming forward much later with much more complex conditions. So you get that answer. And the second answer you get is that, as of today, we have 2 wards full of patients in this hospital that shouldn't be here. And I don't say that cruelly or unkindly. Obviously they need to be here until they can go somewhere else safely. But if the whole system was working better, there will be a better place for them to be that will be at lower cost to the taxpayer. But because that isn't working at a system level, the burden is falling on us as the acute hospital to hold on to them until something can be arranged. So I think there are 2 headline pressures. But what are the other pressures that are kind of giving you a headache and resolving this?
So absolutely, that's quite right, Helen. There is that constant tension around the patients that actually we think could be treated better elsewhere and are ready to go home or to a different setting. What we saw through last year is actually a number of other pressures popping up. So our agency spend is recognised certainly as a regional outlier as an organisation. In particular, medical agency costs are significant for this organisation. So our temporary pay bill is still a real concern and something that we're doing an awful lot of work on as an organisation. There are other things that have popped up. So drug spend is another area that I've highlighted. Actually, we've seen a massive increase in our drug spend since COVID times. And again, other organisations have seen growth in those spend areas, but our growth has been in excess of that in some areas. Now, we're doing some work to understand exactly what's driving those changes and doing some benchmarking to understand where those differences are. But the scale of some of those changes in drug spend is quite significant, actually. But it's the general workforce costs and the agency that are the 2 big areas. And as you can imagine, our regulators are particularly focused on areas of workforce growth. And that's the area certainly where I get quite a lot of lines of inquiry about.
Yeah, no, I can absolutely see that. And there's moral dilemmas as well as operational ones in this, isn't there? Particularly when you look at things like high-cost drugs. Because on one level I go, hurrah! That means that, patients must be getting exactly what they need. And when you think about how far... those snippets I sent around from my current book called Follow the Money to board colleagues about, what the outcomes, the clinical outcomes are in this country vis-a-vis in some of our European neighbours, for things like cancer. And you have a much better chance of surviving and having a better, quality of life after your cancer diagnosis if you're not in the UK. So, when I hear we spend a lot on high-cost drugs, I think, oh, hurrah, that's terrific. Patients must be getting state-of-the-art treatment. And then, you just have to reconcile it with these other pressures. But the reason I'm really kind of feeling it all at the moment is, so our 2 big lines are agency spend and drug spend. But, the plan we've agreed for savings that we've had to, feed back up the chain is that we're going to save 4% or 15.7 million.
Yeah, that's right.
So if we eliminated agency spend tomorrow, which obviously we're not going to because we couldn't give safe care, and if we took everybody off every drug and nobody was allowed anything other than paracetamol, which clearly we're not going to do, we would still, like, there's still a huge gap. So how much would we still have to find beyond those two big headlines, even if we managed to eliminate those areas?
So you're quite right. 15.7 is a savings target. Actually, our agency bill is around exactly that same level. So, as you say.
So in theory, if you could wipe it all out, you'd have solved the problem. But obviously you can't do it that simply.
No, and obviously in theory you'd have to replace those agency staff with substantive members of staff, which would then carry their own costs. So, there is a lot of good work going on drugs, and making safe switches to biosimilars. There's definitely big opportunities there. There's still an awful lot of work in procurement I think we could do. We've seen some good engagement with the divisions on how we switch products or get a bit sharper about how we manage products, and actually there's some big savings to be had there. And that's a really good area where the organisation can engage in, and actually we really encourage people to step forward and kind of highlight areas where we can make savings. Independent sector spend is another area where actually we're doing a lot of work on. So in order to help the waiting list, we have effectively outsourced work to the independent sector, which we're now doing a lot of work to minimise and bring those patients back in-house. Again, that has no impact on the waiting list, but actually is financially beneficial to us. So I think what we need to get better at is really how we do engage with clinical workforce, and how do we get some of these ideas flowing, and how do we really develop stuff. And what I'm really trying to do is foster a culture of people treating the trust budget as if it's their own money effectively, and how, if it was your money, how would you spend it responsibly, and just looking for those savings in the everyday pathways, and how you go about your day-to-day life, because we all see things every day that actually could improve on a little bit, and all those things really do add up and make a difference.
I think that's fabulous, and as we come to the end of our time, I think that's a really good note to end on, because you only have to go out for half a day with a housekeeper, and they will take you to every cupboard on their ward, and they will show you, where they've got too much stock and where they've got too little stock, and, a whole load of other things that on a particular ward may not add up to a whole lot, but add up to a huge amount across the trust. And I think there's something about how we listen to that so we can act on it kind of at a trust-wide scale. But also maybe, Steve, and I don't know if this is fair, tell me if it's not, how it is we empower people more to make those choices for themselves, because I think there's sometimes a bit of I think that would be the sensible thing to do, but I don't know if I can just change that, or I need some help to change it. And do you think there's more we could do to support people who want to eliminate waste and help us, save money so that we can spend it on the right sort of things, about making people better, quicker, and as healthy as they might be in any other country that's considered a really good healthcare?
I do, Helen, absolutely. I think that's a really good point, and I think a lot of organisations have found that as we went into COVID, actually, it had to be quite a centrally controlled approach to almost everything. And as we step away from that, one of the things I'm really keen to do is empower people to make those changes, and actually a lot of the common sense stuff that they see day to day, and make positive changes that can improve patient care and actually save money as well.
And I don't mean this in a kind of presentational way, but I think if we can be having the conversation with more of our colleagues in that way, that's something everybody wants to do, isn't it? Everybody wants to eliminate waste. If you're being called to a meeting to talk about, like, oh God, how are you going to save money, and you've got a target and all the rest of it, you go in with a bit more of a heavy heart, don't you? But if you think actually somebody's really going to listen about all these ways I want to eliminate waste and make things better for the health service, you feel you have the spring in your step. So I think, and I know you and the team are very engaged with this, but I think that's going to be really important in kind of shifting the dialogue and getting us all working together on this.
It is, absolutely, and we're all here to achieve the same thing ultimately, Helen, but I think that's a really good point.
Thanks, Steve. I've enjoyed that chat. If you've been listening, I hope you've enjoyed it too. If there's ever anything, you'd like us to have a specific focus on, as we reflect on what's happened in our board meetings, feel free to give us suggestions.
Thank you, Helen. Thank you, everyone.